Welcome to the AOA Future in Orthopedic Surgery podcast series. This AOA podcast series will focus on the future in orthopedic surgery and the impact on leaders in our profession. These podcasts will focus on the vast spectrum of change that will occur as the future reveals itself. We will consider changes as they occur in the domains of culture, employment, technology, scope of practice, compensation, and other areas. My name is Doug Lundy, host for this podcast series. Joining us today is Dr. Alex Vaccaro. Dr. Vaccaro graduated summa cum laude from Boston College with a BS in biology, and he received his medical degree from Georgetown University School of Medicine. He completed a year of internship at Cedars-Sinai and then completed his orthopedic surgery residency at Thomas Jefferson University. Dr. Vaccaro completed a spine fellowship at the University of San Diego, followed with a PhD in the field of spinal trauma. He later received his MBA from Temple University's Fox School of Business in Philadelphia. Dr. Vaccaro has served as president of Rothman Orthopaedics since 2014 and is the Richard H. Rothman Professor and Chairman of the Department of Orthopedic Surgery and Professor of Neurosurgery at Thomas Jefferson University in Philadelphia. He specializes in the comprehensive treatment of numerous pathologic conditions affecting the cervical, thoracic, and lumbosacral spines, including degenerative disc disease, scoliosis, and other deformities. He was the recipient of the Leon Wiltsey Award for Excellence in Leadership and Clinical Research for Spine Care by the North American Spine Society and is the past president of CSRS and the American Spinal Injury Association and the Association for Collaborative Spine Research. In 2000, he was selected to be an AOA Japanese Orthopedic Traveling Fellow, and in 2003, he was selected as a Scoliosis Research Society Traveling Fellow, where he toured and lectured in Turkey and Western Europe. He has over 1,200 peer-reviewed articles and over 225 non-peer-reviewed publications. He's published over 380 book chapters and is the editor of over 65 textbooks and the co-editor of OKU Spine 1 and editor of OKU 8. And Dr. Vaccaro also serves as the co-director of the Regional Spinal Cord Injury Center of the Delaware Valley. Dr. Vaccaro, sir, thank you and welcome to the AOA podcast.
Thanks, Doug. Nice to see you.
And Alex, you and I have several things in common. We both live here in Pennsylvania, but also we both have had the opportunity to lead some of the largest orthopedic practices, private practices in America. And our point today is, what is the future in orthopedic surgery as it relates to the megagroup? And within the Ortho Forum, we define the megagroup as being over 100 doctors. And of course, Rothman clearly serves that. Can you tell us a little bit, if you would, about Rothman and about what y'all are doing down in Philly? And
sure, Rothman has,
you guys are all over.
Yeah, well, no, we're everywhere. So Rothman has about 270 providers, and the definition of a provider is an orthopedic surgeon, a PA, or nurse practitioner. And we are presently in New Jersey, Pennsylvania, and Florida. And like any large group, and with changes in the medical economy, we've experimented with different models. Now we're working on a regional model. We expanded to different areas. We keep economies local. And what I mean by that is we used to leverage our size and our ability to negotiate, but as insurance companies for each state is different. So if we have a stable rate system in New York, it doesn't mean it translates to a stable rate system in New Jersey or Florida. So it doesn't work that way. And what happens is people get in the group, want to have the best rates possible. So we went through models where we took our rates, we tried to homogenize that concept throughout, and that failed. We had different relationships, and the relationship we found that worked the best is teaming up with a very large, successful healthcare system and using them capitalize our startup, get involved in the market and brand, and bring the Rothman brand. And the Rothman brand is focused not only on patient excellence, but also on research, education, and disseminating clinical practice guidelines and taking patient-centric care to the population. So that's our model now. And we went through a sort of a stall during COVID, like everyone did, because we didn't get the type of financial support because we were so large from the federal government. And we went through some trying times, but we've rebounded. We're back on track, and we're beginning the growth cycle again. So that's, and to jump into where we have to go in this podcast, we have to look at the forces out there that we're competing with. And you said it before, Doug, what is the future of a mega group? and I look at three competing factors. I look at private equity as one. I look at large healthcare systems, and they can be defined as like an HCA or a medical healthcare system. And then third, a mega group. And who will survive in the future? Who will bring satisfaction to the providers, and who will provide the best care? And that's what we're challenged with. And I have an opinion on all three of those models and where we're going to go. So I'll let you direct me, and I'll give you my opinions on each one.
Thank you. You're clearly the right guy to talk to about this. Now, one thing that I think people don't necessarily understand is that leading in a group like Rothman, like IBGI, like OrthoCarolina, like Resurgence, like any big or even medium-sized private practice group, is that you're leading a bunch of shareholders. Your doctors are not necessarily employees. There is a quote unquote employee portion of what they do, but it takes a whole different brand of leadership than it does for me now in hospital/academic organization where the doctors actually work on the org chart. They're underneath me. But in the private practice realm, you're leading shareholders that you have to persuade, y'all follow me this way, because they don't necessarily have to just follow you just because you say so. So can you elaborate a little bit on your leadership style and how that's all worked out up there?
Doug, that is such a great question. You get into this sort of trance where when things are going well financially, everyone seems to be rowing in the right direction. But you have to look at a group our size. We're in different states, different regions. And I almost talk about different communities of orthopedic surgeons. The needs and responsibilities and desires of a Southern New Jersey doctor may be different than a Central New Jersey doctor compared to a Northern New Jersey doctor. Workman's comp, personal injury, motor vehicle accident, commercial insurances may be different. Medicare Advantage plans may or may not be different. Hospital relationships may be different. And if you look at just where I'm in Southeast Pennsylvania, we work with four major healthcare systems, and each one has a different deal with us in terms of trauma care and so forth. So you're representing doctors that if things aren't going well for them in their particular region, they may not be on board. So you're constantly trying to be like the Soviet Union back in the 1990s, keep everyone together. And then once the money runs out, or once you're having trying financial times, things get difficult. And I use this economic term, the Pareto principle. 80% of the time, things are going well, and 20% of the times, things are not going well. And it's our job to keep people together during the trying times. So you and I have leadership difficulties when we're under financial difficulty. So take us back to 2021, 2022. Our expenses were about 35 million a month to keep Rothman Institute going. And all of a sudden we closed down for 5 months. Like we had no revenue coming in at all. So we're private practice. So we had to furlough. Now, I want you to think about this. 28 physicians. So what does that concept of furlough means? It means, by the way, we can't pay you a salary. I can cover your health care and I can cover your benefits. And they're like, what are you talking about? I went to med school, I went to residency. I'm a accomplished orthopedic surgeon. And we're like, we have no revenue. And then we couldn't do anything. I was in the city of Philadelphia and my PA walked up to me and said, we're not allowed to see anybody. I'm gone. So now we had our ancillary support leave. It was a difficult time. And then we went through that post-COVID. It was an infusion of capital. Everyone was happy. And all of a sudden, wages went up, cost of capital went up, interest rates went up. And all of a sudden, what cost me in 2021 to run a business really magnified in 2023, 2024. And then you saw the orthopedic surgeons getting upset. So we learned a few things about the business of medicine. And it's a concept that we're evolving called flexed working force. Like when we go through difficult times, we have a stable working force of 2/3 of our people, but a third can flex up or flex down. So if the revenue's coming up, everyone's doing well, and the distributions are good, we go in one direction. If we start having difficulties with certain payers, we have to pull out, we can flex down our workforce because you can cut expenses to balance your portfolio, but cutting expenses doesn't lead to enrichment of the group itself. So we flex our expenses depending on our revenue, and then we grow when things are doing well. And that's how a mega group can survive today, because you and I both know our reimbursement from CMS is just creeping down slowly. We know that we're not keeping up in commercial with inflation and the consumer price index is not keeping up. We're maybe getting a 1 to 3% raise in what we get from our commercials. It is not keeping up. So what do we do in private practice? We have to flex down in terms of our expenses, and then we have to look at other revenue lines. And they have to be ethical and appropriate revenue lines. Like when stem cells were introduced to orthopedic surgeons, we took the position that we were not going to get into that business because there's no science behind it. And if the sports medicine physicians and the shoulder and elbow surgeons wanted to do it, they would have to create a registry, and they would have to commit money financially from whatever money was brought in to study the outcome. And if it wasn't going in the right direction, they would have to withdraw from that business line. So you and I know that we have all these different ancillary lines in orthopedics. Some are effective, some have gray areas, and some are clearly not effective. So we took the position we will only stand behind effective ancillary revenues. So we have to, as a business, be like a business. We have to make sure that our balance sheet is appropriate. We have to make sure that our income statement is profitable at the end of the day. We have to maintain distributions because, as you said, the vast majority of orthopedic surgeons are busy with their life. So when they start seeing less and less, they start questioning leadership, what's going on, and they don't see the macro economics of what's going on, and they certainly don't see the microeconomics within our group itself. So it's our job as leaders to maintain that equilibrium where we can maintain revenue as we're exploring different business lines and fighting the challenges. And every day, I must spend 6 to 7 hours a day running the business in addition to being a surgeon. And that's the headache. And being a surgeon at our age, you and I look like we're the same age. You're much more handsome than I am, but we look like the same age. We know what it's like. You have to maintain patient care, but that's the easiest part of my job, is doing office hours and doing surgery. The most difficult part of my job is when an insurance company stops paying me, or a healthcare system stops supporting call pay, or we find out that we're getting sued by whatever, and now we have a legal problem. That's the headaches we live with as leaders in orthopedics. And if you don't pay the masses, they're shareholders, and they demand to get what they believe they should get. So that's a challenge we live.
And it's so hard because when you're doing everything right, so of course you are, but they'll let you know when you're not. How many ASCs do y'all own?
It's interesting. During the COVID, we were up to 18.
Wow.
Now we're down to 12, and we have 2 specialty hospitals. And that's a whole discussion in and of itself. We're evolving because the pressures we see in our region is anesthesia support. We're literally in a conundrum now where we're the engines before. We have hospital partners, we have miscellaneous smaller partners. But the biggest challenge we have is our anesthesiologists are coming up and saying, we can get paid a lot more over there. So for you to run an ASC room, we would like you to pay us an additional stipend. And I'm like, what does that mean exactly, an additional stipend? We're not happy with our CMS reimbursement, so we want X amount of dollars to run a room. And if it goes past 3 o'clock, we want an additional monies for that. So we have to reinvent that whole support system. And I've seen different models come through. So the headaches we have with ASCs are that, and we have a different model at Rothman. If you look at a lot of the mega groups and other independent groups, individual doctors will buy into individual ASCs. We don't do that. We socialize it, and we democratize our revenue. So once you show that you're committed to an ASC environment to operate, once you do a certain amount of cases, you can then buy in. And we, instead of looking at the market value of an entity over time, we decided we were going to take the last 3 years of distributions, and that's what, because we want a cash and cash return in 3 years. So if you put $1 down, you want to make $1 within 3 years. So before, these surgical centers, oh, they're worth $1 billion, right? They're like so expensive, and then no one can buy in. That's not a viable business model in the future. So we're constantly evolving our retirement scheme. We're evolving our ASC specialty hospital ownership scheme, and we want to make it fair market value, like the real estate market. If you produce and the distributions are X over 3 years, if you want to buy in, that's what you have to pay. Because surgeons want their money back. Surgeons want their money back. And then when you go around the country, everyone talks about how much money they're making in the ASCs. We clearly don't make that kind of money at the Rothman Institute because we divide it up among all the partners. So you can imagine what appears to be a lot of money gets divided up into a much smaller amount of money. So we're constantly evolving that relationship with our healthcare partners. But our biggest challenge in that respect is anesthesia coverage. And you probably see the same thing up at St. Luke's, I would imagine. Maybe not. I mean, it's a headache down where I'm in the city.
Yeah, I think we're a little more insulated being out here in a lot more of a suburban rural area than y'all are. For those of y'all who don't know the geography, I'm probably about an hour and a half north of Alex. So this is all the stuff that I think that what you're describing is how the leadership of the mega groups and my friends at the other mega groups say similar things in terms of the way that you see the future, whereas you're looking hard for the obstacles and challenges that y'all are going to face in the future. What's coming down the pike? How can I position Rothman correctly so that we're in the best position for this? Because if anything, you're way more nimble than the large healthcare systems. You can get around things, you can get there faster and be ready for the next challenge. And this, I believe, is one of the advantages of the mega group, because there's so much relying on you to get this correct. And you have so many more potential resources than much smaller groups have. I think that in many ways, the mega group has the capacity to handle the upcoming challenges and crises in healthcare far better than other private practice models. What do you think of that statement?
I agree. So let's talk about growing the business. So when I go to hire an orthopedic surgeon, I know how much I can afford to pay, because we're not going to get a return on that investment for 2 to 4 years. So all of a sudden, private equity comes in, and private equity came into our area, and they're paying 2 to 3 times what I can pay for a surgeon. And then the healthcare systems want to maintain market share, so they're pushing for a more universal employed system. And I'm looking at what they're paying a spine surgeon. I'm like, okay, that's about 2.5 times more than I can pay. So that's the challenge that a private practice group has, because the graduates, and you and I know the numbers at 75% people coming out that are now going into an employed model. So I have to show them that I know you have a $300,000 to $400,000 debt. I know you have to buy into the partnership. I know you have to buy into the ACs and specialty hospitals. I know you have to buy into the real estate. I know you have to buy into the real estate, but I want you to come with me. And I know you're going to get a guaranteed payment from this healthcare system. So the way we survive in that environment is that we have to show the healthcare systems we work with it's a lot more economical for you. It's a lot less headache for you if I control the orthopedic providers. You don't have to get into the downstream headaches of employment and so forth. I said, we can do that for you. And we have to show the healthcare systems that we can provide that value, and it's a lot less expensive for them. So if you look at Thomas Jefferson, for instance, there's only 2 private subspecialties of Thomas Jefferson: ophthalmology through Will's Eye, which is separate, and then orthopedics. Everyone is in a fully employed model. And Jefferson has expanded into hiring more orthopedic surgeons. So the way we can tell we're doing well is that the employed orthopedic surgeons, what are their satisfaction levels? And are they asking Rothman to employ them? And we're noticing that's been the case so far. And we have to prove to our healthcare partners, and we get along well with them. We're with Capital Health, we're with Atlantic Care, we're with Thomas Jefferson University, so locally, and we have great partnerships with all 3. But I have to, and my biggest headache is the initial salary for these young graduates. It's crazy what they're being paid. Now, if you look at a private practice and private equity, and I study the private equity model, if you don't have a second bite of the apple in general, you will start losing money as a provider at 7 to 8 years. If you do the math, and the math is complicated, but if you really do the math, and most orthopedic surgeons don't understand the math. They see the initial infusion of money. They don't understand that they're going to have to pay the interest on the debt. They don't understand what it means to roll up part of their money into the MSO that has to be sold in the future. They don't really understand that concept. But if you follow the math closely, at 7 to 8 years, you are losing money as a provider. You are losing money. And we're seeing the markets now not being capitalized. We're not seeing second and third bites of the apple. So these orthopedic surgeons are getting upset. So in our local market now, we have an influx of people in private equity saying, I need to get out. Can I join you at Rothman? And we say, sure, but we're not giving anyone that sort of, we're giving you a ton of money to join us. We're going to give you a stable job, but you have other responsibilities. You need to teach, you need to do research, and you need to publish. And a lot of people aren't into that. But if you're into that, we believe our model is the best model in the future.
That's fascinating. So clearly you guys have a path for the future. And like I said, and can you talk a little bit of, you already have it, can you talk a little bit more about your resilience to be able to adapt to change, to adapt to crises, more so over other models? And then secondly, I also want to point out for the folks that are not in this area that of the two private practice groups at Jefferson, you guys and the ophthalmologist, both your names are national brand names. So it's not just mom and pop shops that are private practice. Clearly, Jefferson recognizes that they can't reproduce what you guys and the ophthalmologist are bringing to the show. So if you could tell us a little more about the grit, the versatility, the adaptability that y'all have in adapting change in the future and crises, how you guys can respond to that with more resilience.
Sure. So if you look at our income statement, I always talk about the revenue that comes in, our cost of goods, or the salaries that we provide, our care providers. And then you go through the SG&A and all the expenses come out. And then you're left with your EBITDA, which is what our gross margin is. And then you pay the taxes, amortization, depreciation. And what's left over, we take that money and we bring it back and divide that among the partnerships. But we were hit with pretty significant expenses. We were involved in a professional athlete liability suit where we got hit for $16.5 million,
Wow.
not covered for insurance. So we had to go back to the partners and say, oh, by the way, everybody, we have to pay $16.5 million. So you could just imagine. So that made it very clear to us that we need to be resilient in a way that we have to build and shore up our ancillary revenue line. We have to really firm up our strategy on ASC. And in the ASCs, we went into a model about, I'd say maybe 10 years ago, of developing stay suites where people can stay an extra night. Because in Pennsylvania, even though it is now 23-hour stay, it's really 6-hour stay because even though the Department of Health never really certified it. So we had headaches in Pennsylvania for 23-hour stays. So we figured out, in order to blunt and to stay viable and to stay productive, we needed to shore up other revenue lines. So when we get hit with one of these externalities that affect our balance sheet, we can survive, because there's nothing partners hate more than a capital call. Capital call because of a bad investment, anything that can go on. So those are the things that we have to focus on. So our resiliency is built on diversifying our revenue stream, because the money isn't going up from Medicare. The money's not going up from the commercial, besides a small rise. And occasionally, one of the large insurance companies will come back and say, we're cutting rates below Medicare. And we're like, what are you doing? And then we have to get out of it. So we can't do that. So our resiliency is built on offering other business lines. And if you want to talk about them, I can, but there's so many different creative ways of bringing revenue in that you can. Because the other thing we have is that we used to have a point system where we would give you points if you presented peer-reviewed papers at the academy, if you belonged to the AOA. We had a point system to do that. What happened, Doug, is that as we got to be so big, there were more non-academic physicians in our group than academic physicians. And the non-academic physicians really didn't see the logic of, why are we giving part of our revenue distributions to the academic guys? That didn't make any sense. So we socialized that. We'll provide you more money if you're a professor, a little bit less if you're an associate professor, and a little bit less. But we got away from giving points out. So we give very little money out. But we used to have a model where we really did invest in, if you really were dedicated to academics. But once you get above 100, most people aren't into it. Like, I always laugh, as a part of the residency program, the fellowship program, everyone that interviews with me says, Dr. Vaccaro, when I graduate, I want to be a professor at a leading academic institution. And I'm like, okay, you're lying to me, but thank you very much for saying that. That is the biggest lie I've ever heard in my life. And that's what happens, because people want to have a life. They want to go, they want to hang out with their family and stuff like that. So that model, our academic model, changed. So today, the way we survive is by developing revenue lines outside of going to the operating room, because that's the worst predictable revenue line I have today. You and I can only do so much indicated surgery, period.
And you just walked right into what I was going to ask you in terms of, as CMS goes, so go the rest of the payers. So as Medicare continues to march down and cut down what they're going to pay, it seems like y'all are in the right position to weather the storm as much as possible, because once they hit the bottom, then of course they're at the bottom. But until then, CMS is going to continue to lower down the conversion factor, and the smaller practices won't have the ability to respond to that, to the flexibility that you guys have.
100%. I look at the race to the bottom. When bundle payments came out, we were so aggressive. We championed them, and then you could clearly see it was a race to the bottom. They kept on comparing the outcomes to you from the last 3 years, and they paid less and less. And we had to pull out of the Medicare bundle payments, and we had to go through a percent of spend of the MSK population in a region. And we come to the point where you have to pay for value. And I always laugh where everyone's definition of value is different. Everyone's definition of value is how can I get the most money for what I'm doing in my region, and what's my leverage and what's my clout. So I think the true point of value-based healthcare is providing the best care in the most inexpensive, safe environment, do the least amount of intervention that you can, and get a patient back to being productive. That's value-based healthcare. And then coming up with a reasonable negotiations with the insurance companies. And you and I can't negotiate with CMS. We don't have that ability. And so we'll just never be able to do that. But take a Medicare population. Can you provide further value to that population of those that can afford it? Can you create a concierge service for a Medicare patient? Can you provide services outside of what is reimbursable to make their life more comfortable? Can you provide transportation? Can you provide valet park? Can you make it so you can develop other business lines? They will appreciate if they can afford to do that. That's will allow us to continue to maintain care for those populations. And then when it comes to the uninsured, underinsured, or the Medicaid populations, you develop relationships with your healthcare service because they're safety net hospitals, they make a small margin. So can you get support so you don't lose money caring for those patients? That's the key thing. For the Medicaid population, you can't lose money because then you're out of business. So can you work with your local healthcare provider and say, listen, we know this benefits you caring for them, but we can't lose money. Can you just maintain neutrality there? And we'd be happy to continue to provide care. That's the best business model to make sure that all segments of society are cared for.
Do you think there's some degree of halo effect that a mega group like Rothman could have within the southeastern Pennsylvania area for, say, medium-sized groups that are there saying, yeah, I'm not Rothman, I'm 40 to 50, 20, 30, whatever, orthopedic surgeons in my group, and I don't have the leverage and the versatility or I can't think of the correct word, to deal with change in the future with that. But because Rothman's doing it, I can follow in their wake and take advantage of some of the changes and the effects that they've had with that? Or do you think it's really, if you're not part of one of those three big ones you talked about, private equity, healthcare systems, or the mega groups, is it pretty dismal? What are your thoughts?
I think you can survive. So let's look at what was the first assault, for whatever reason, on the private practice. It all came out through the ASA, Obamacare, when they required electronic medical records. That was a major financial burden to a healthcare provider. That cost so much money. That was the beginning of the healthcare provider losing autonomy. Now, I like the concept of centralizing information, developing large registries, using AI to extract what's the best treatment models and so forth. So I like the concept, but the burden fell on the physician groups. And you and I know it's so expensive for a 10-man group, 15-man group to do that. Plus, they didn't have negotiating prowess. So I think the insurance companies, Doug, if they look closely at the cost of care, if they look at what it costs to go to the main university, which should be a tertiary and quaternary center, and they look at a smaller 10-man group, they can negotiate with those providers and say, listen, we'll pay you more what you need to survive because we need more of you. Because I'm not sure the insurance company is going to be happy having these merged healthcare systems negotiating with them. They're not going to be happy. Like anything else in life, everyone wants everyone to survive because everyone can bring to the table negotiating prowess. Keeping private practice alive, in my opinion, will decrease the cost of care. Having these large, massive healthcare systems with leverage will increase the cost of care. So I think a smaller group with the appropriate leadership can negotiate and get greater rates. Because I know in my local area, the leaders of the smaller groups will come and say, listen, this is the rates you give, blah, 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 blah. You need to maintain because we're going to go away if you don't. And then you're going to have to pay a lot more if they go to the main university.
So how does the private equity side affect into the future of the survivability of private practice?
I don't think it's going to, the model they have today, and I'll give you an example. A typical model is coming in, looking at EBITDA, And EBITDA, the multiples of EBITDA change. I think right now the multiples on the markets now are 8 to 10. Say that's in general. 7 years ago, it was 13 to 17.
Yeah.
So if you look at that multiple in EBITDA, and you look at the fact that you as a doctor get a little bit of a cash infusion up front, and then your lifestyle has to change because now you have a scrape. And that scrape can be 25 to 30%. And they don't care where the money's fungible. So it doesn't matter where the money comes from. It can come from your PSR, it can come from your ancillaries, it can come from your facilities. But that 30%, so a guy making 750 after servicing a 6% debt on the loan that the bank gave him, which went into his pocket, he's going to be taking home about 400,000 and 750. Number one, we're not good at doing that. We're
Or
not good at
taxes.
yeah,
Right.
we're not good. We're not good at getting 700,000 a year, which sounds like a lot of money, and all of a sudden getting 400,000 a year with the same lifestyle. So in general, professionals not that good at changing that lifestyle. And then you start seeing that money. Now, the only way private equity is surviving is if they do everything that they espouse to do. Can they take fragmented care and make it consolidated? Can they go into the back office? Can they use scale to get better rates? Can they use scale to decrease accounting, all the different things that you have in your back office? I haven't seen them get better rates. That hasn't happened. I'm sure they can scale up in terms of buying insurance packages and stuff like I'm sure they can do well, but I haven't seen the income repair. So what I try to do is I try to study every publication that comes out in the business journals. What percent income repair has been demonstrated by private equity in the orthopedic space? And it's about 15%. 85% of the time, you're never making that money you give. So if you give that scrape, you need to get a second bite by 6 to 8 years. And if you don't get that second bite in 6 to 8 years, you are now losing money. And so what I've seen a lot of guys call Rothman and say, I would like to join you. And of course, I spend most of my time saying, listen, tell me about your journey. And that's how I learn because I haven't seen it published. You and I have seen locally how private equity is being demonized because all these private equity owned hospitals are collapsing. And I never really know, should they have collapsed anyway? What was their business model? Did they run the ship poorly? I don't really, you and I don't know. All we hear is what the press tells us. But I do know from my friends who are in private equity how unhappy they are now. And the only guys that aren't unhappy is if you have a horizon of 5 to 7 years left in your practice. Then you're probably pretty happy because you got your money, depending on the covenants they put on you, because you're an older surgeon, they're pretty happy. And then they retire. I just got a phone call yesterday from another local surgeon who wanted to sell me his practice because now their non-compete time period is up for this particular local private equity deal. And I said, sure. But I said, we'll talk to you. So I think that's what's going to happen. Now, on the employed side, I want you to think about another concept of what's going on. So it's an RVU war.
Right.
But one thing these hospital systems haven't seen is the concept of collective bargaining. So I'll give you an example. So I sit down with these new orthopedic surgeons that come to me and they say, listen, I know I can make this much from you at Rothman, but this institution is going to give me X amount of RVUs. This is my bonus level, and this is what I get paid. And then I do the math. And I'm like, you're in an inner city, so you're going to have an underinsured patient population, probably 60% Medicaid and underinsured. I go, you're never going to make that money that they're paying you. So they're going to get paid. So the healthcare systems, once they realize that, and you and I have seen the financials in Philadelphia, you read the papers in the last couple of weeks, healthcare systems are struggling in Philadelphia. So they're going to say they can't afford it. Doctors are not. There's one thing people don't like is when you take someone's apple away from them. If you give someone something and take it back, they don't like it. Second thing, collective bargaining, these surgeons are going to get tired of just churning, RVU churning, and they're going to say, we want other things on our contract. We want time off, time for family time. We want PT, paid time off for, they're going to start coming back collectively because now we're seeing unionization happening. Thomas Jefferson became a union residency program 2 months ago. I don't know if you knew that.
Yeah.
Unions came in, now all the residents, and I'm not sure if the fellows are involved, but the residents are. We're going to see the same thing with the physicians. They're going to say, listen, and they're going to start saying, thank you for all this money for the RVUs, but we want more. We want to change our lifestyle. And then the healthcare systems who are hemorrhaging money now are going to have to look back and say, what are we going to do? Again, it makes private practice more attractive. Now, the headache I have is the insurance companies. As long as they continue to understand that and support us, we'll be okay. The second the insurance companies decide that they're really going to cut the rates to be like CMS, that can collapse the system. So as long as they will play ball with the private practice practitioner, we will do. That's my headache. I just got to make sure that they don't decide we're going to really cut the spigot like CMS did.
Now, in terms of consolidation, you guys have done quite a bit because you've expanded to 3 states now, I believe.
Yeah, 3 states.
Florida, New York, or Florida, New Jersey.
In New Jersey, Pennsylvania, and Florida.
Yeah. And when I was at Resurgence, we were just in Metro Atlanta. Since they've undergone private equity acquisition, they've spread out quite a bit more. But in terms of in the future, do you see the mega groups consolidating into, do we see potentially Ortho Carolina, Ortho Virginia consolidating and other bigger groups doing that? Or do you think that the nimbleness and the local savvy that the mega group has for their individual area is going to keep them pretty much from consolidating across the nation?
So here's a headache. All economies are local. Keep that in the
Right.
back of your mind. So
Right.
it's not like we have a national or a international business model. My revenue, and I make my money in Philadelphia because of my relationships with the local Blues and the local Aetna and so forth. They have a whole different payment scheme in a different state. So that's one of the reasons why that won't happen. So I think the future model is getting a capital partner, such as a large healthcare system, that says, we want you to be our orthopedic provider, and we will help support and capitalize the underinsured. We will maintain a reasonable level of income to your group. I think that's how these mega groups will spread. And that's our model. We go into a healthcare system. We can't say to the orthopedic surgeon down in Florida, where their rates are a lot lower. It's a Medicare population. So if you look at the Blues in Florida, they pay less than the Blues in New York. So you can't go down and say, listen, join the Rothman Institute. We're going to give you the rates up here, which is what everyone wants. They want, we're in this group. Why don't we all have the same rates? And we say, no, that's great. But this is a state mandated healthcare reimbursement system. That's not how it works. But we're going to pay you the best you can get paid in that state. Then we use the mega group brand for economies of size. Maybe we can do a malpractice insurance, but again, that may be state specific also. But we can do a lot of back office stuff. So it's almost like a federated model. Will economies of scale, the different services we can provide across state lines. It could be advertising, it could be whatever, but there's certain things we can't. We'll help you negotiate a platform. We'll introduce a brand. If you take a look at, and what gave us the idea was watching Cooper Hospital. Cooper did well in their cancer care because they teamed up with MD Anderson in Texas, and they took their clinical practice guidelines and their support, and they plastered MD Anderson on the outside. And by the way, that was the greatest thing they did in the world. And I went over there years ago, like 2017. I went to meet with their president, like, tell me how this whole thing works. And they told, and I said, I am going to do that at the Rothman Institute. And we were able to take what we do best, which is basically studying the science of these healthcare models, in addition to academics and research and publishing. And we said, we'll bring that to you. Is that a value added to you? And if a healthcare system says, we like that, we like the fact that we can be rated in the US News and World Report. We like the fact that we want our surgeons locally to be published because we can use that as brand advertising. If they buy into that, that's how a mega group grows. It does not grow by socializing our contracts, because that doesn't exist. I can't socialize my contracts in Pennsylvania down to Florida. That doesn't happen. It doesn't happen. And no one knows that, by the way. No one understands that. So that's why these big mega groups have a difficult time going to different places. It's a whole different model.
Wow, this has been fantastic. I really appreciate it. I wish I had talked to you more about this when I was down south. So to sum things up, as a parting blow, what do you, if you had to give the elevator speech on what's the future 10, 15 years, 20 years, however far out you feel comfortable going, of the mega group in orthopedic surgery in the United States, what would you say?
It's going to do well. It's going to continue to grow because competition exists everywhere. Every time we falter or stutter in one location, there's always another partner that wants to grow. As long as we have a growing healthcare system in any state that wants to grow and get bigger, the mega group orthopedic surgeon will have an opportunity. Now, you and I make money, and I always tell every orthopedic surgeon, we make money by breaking bricks, by providing great care. If you think you're going to make money on these little fringe business lines, such as personal injury, legal, motor vehicle accident, workman's comp, you will eventually fail. because the laws will change. You need to develop a business model where you can take care of the CMS patient in a basic insurance plan and then be viable in that setting, and you will grow bigger. You and I know orthopedic surgeons that do very little surgery and do well financially because they're in the workman's comp space. But you and I know those laws change all the time.
Right.
The only thing I pray every day is for tort reform. I wake up every morning and I say 10 Hail Marys for tort reform, especially in Pennsylvania.
I'm with you there, 100%. Wow, this has been an absolute pleasure talking about the future in orthopedic surgery, specifically with the megagroup from Rothman Institute President, Dr. Alex Vaccaro. Dr. Vaccaro, thank you for joining us, sir.
Doug, it's always a pleasure. I'll see you soon, okay, my friend?
Yes, sir. Let's do it. I look forward to it. I want to come down and visit with y'all. And you all visit us again on another AOA Futures in Orthopedic Surgery in this podcast series.